Good day, everyone. I'm John Lim. Thank you for inviting me to give you a talk on PRP, why, when, and how. I have no financial disclosures for this talk. Outline of my talk is as follows. Why do we do PRP? When we do it, how we do it, and when do we refer? And after the lecture, I'll have 5 cases of my patients that I'd like to share with you. So why do we do PRP? So PRP is indicated to treat retinal ischemia and retinal neovascularization from whatever cause, but particularly for proliferative diabetic retinopathy. The landmark study, diabetic retinopathy study in the 1970s, demonstrated that PRP reduced the risk of severe visual loss by more than 50%. Untreated eyes had a vision loss rate of 16.3%, while treated eyes only had a vision loss rate of 6.4% over 2 years. Eyes with high-risk features received the greatest benefits. The DRS, however, did not determine when, in the course of the disease, PRP should be done. The early treatment diabetic retinopathy study attempted to examine whether early PRP was more effective versus deferred PRP. The ETDRS advised against PRP for mild cases of NPDR to balance the potential adverse effects and relative risks of treatment against the minimal benefits gained by treatment at early stages. PRP is to be initiated when NPDR becomes more severe or progresses to PDR. Studies on the use of intravitreal injection of anti-VEGF have shown similar and probably superior outcomes versus PRP in eyes with diabetic retinopathy. Panorama evaluated the efficacy of aflibercept injection with moderate to severe NPDR without diabetic macular edema. The results showed a statistically significant 2-step improvement in the DR severity score, and DME development was also lower in treated eyes. Protocol W also evaluated the efficacy of aflibercept in moderate to severe NPDR without DME. There was a 3-fold relative risk reduction in preventing center involvement of DME with vision loss or PDR at 2 years. However, in both studies, there were no differences in visual acuity between the groups at 2 years. Protocol S showed that ranibizumab was non-inferior to PRP in the treatment of diabetic retinopathy with high-risk features. Visual acuity outcomes were better at 2 years and throughout the study period for patients who had ranibizumab alone. This was also better for those who had DME versus those who did not. The PRP group seemed to do much worse in visual field outcomes. However, at 5 years, mean change in visual acuity in the two groups was similar, and visual field loss in the ranibizumab group approached that in the PRP group. Fewer patients developed DME and RD in the ranibizumab group, but the PRP group had fewer visits and injections. Both groups had an incidence of vitreous hemorrhage of almost 50%. Take note of the 34% 5-year overall dropout rate, which was quite high. Of those lost to follow-up, half had anti-VEGF alone and half had PRP. A major concern in eyes treated with intravitreal injections of anti-VEGF alone is the risk of PDR progression if patients are lost to follow-up. So why do we do PRP? Although studies on the use of intravitreal injection of anti-VEGF have shown possibly superior outcomes to PRP in eyes with PDR, these studies were strict on injection and follow-up protocols, which are actually not practical. A study in Wills Eye Hospital compared anatomic and functional outcomes in eyes with PDR that were lost to follow-up for more than 6 months after either injection of anti-VEGF or PRP. Eyes that received only injections had worse visual outcomes and had a greater number of eyes with traction retinal detachment and iris neovascularization at the final visit. This becomes especially relevant in our setting where loss to follow-up is very common. As much as we can, we adhere to the DRS and ETDRS recommendations where eyes with PDR high-risk features benefit the most from PRP. More severe NPDR can also benefit from PRP, especially in patients who have poor follow-up. A study showed that there is significantly higher visual acuity outcomes at 18 to 24 months post-PRP in patients treated on the day of diagnosis. Furthermore, patients who receive PRP within 31 days of PDR diagnosis have superior visual acuity outcomes at 1 to 2 years when compared to delayed PRP. Therefore, the optimal treatment approach is PRP on the day of diagnosis if possible, or within 1 month. Conventional PRP is also called long-duration PRP, which was the one used in DRS. However, some modifications have been made as the DRS settings are associated with high levels of patient discomfort as the burns are delivered individually. Conventional PRP usually uses pulse durations of 100 milliseconds, large spot size of about 200 to 500 micrometers, with 200 to 250 milliwatts of power. Personally, for conventional PRP, my initial settings for a Mainster 165 PRP lens are as follows. I use 200 micrometer spot size, which results in a 400 micrometer spot size on the retina, 100 millisecond spot duration, a pulse duration, and starting power of 180 to 200 milliwatts. Of course, it is tricky to assign standard settings because the quality of your burns are really dependent on several factors, particularly media clarity, pigmentation, and laser type. Short duration PRP utilizes pattern scanning laser, which delivers a pattern of multiple shots in the same or less amount of time that conventional lasers take to deliver one burn. Because of the speed of delivery, we can afford to use shorter pulse durations of 10 to 30 milliseconds per spot, which needs to be balanced by more total shots. Personally, my usual settings for pattern laser with a Mainster 165 PRP lens are as follows. I use 200 micrometer spot size. I start with 20 milliseconds of pulse duration, 200 milliwatts of power. And again, the settings really change because they depend so much on media clarity and fundus pigmentation. Conventional single-shot PRP tend to have bigger spots through time, as shown in the left photo. It's because of the longer duration. The spots tend to creep and have the tendency to become confluent. In pattern laser, where the duration is shorter, the laser scars do not end up as big as longer duration PRP. That is why pattern laser PRP must have more shots to compensate for shorter duration and achieve the same effects. Pattern shots also can be spaced closer together, like 1/2 spot size in between shots. As recommended by the DRCR network procedure manuals, the retinal burns must be mild white. The edges must be 1 burn width apart, but it can go as close to 1/2 burn width apart for pattern laser as it is of shorter duration. Nasal proximity to the disc, as recommended by the DRCR network, should be no closer than 500 micrometers, which is about 1/3 the disc diameter, or approximately 1 burn width apart. 1 burn width. The gray circle shown here is about 1 disc diameter, and it is also safer if you spare about that size for initial PRP according to the DRS. The temporal proximity to the center should be no closer than 3,000 micrometers or about 2 disc diameters. For initial PRP, you may set it at no closer than 3 disc diameters as indicated by the 3 gray circles because it was the one initially recommended by DRS. Superiorly and inferiorly, as much as possible, stay outside the arcades. If you have to go within the arcades, do not go further posterior than 1 row within the temporal arcades. According to DRS, you do laser up to the equator, but if you can, beyond the equator, you may add laser marks if the view permits, as more laser shots are better. As mentioned earlier, pattern scan needs more final burns than conventional laser. More than the total burns, however, the adequacy is more important. Oftentimes, I go as high as 3,000 plus shots in pattern laser. The clinical goal is to administer enough laser burns to ischemic retina to induce regression of NVs and prevent new lesions or hemorrhage. For conventional PRP, I usually finish in 2 sessions per eye. And for pattern laser, I usually finish in 1 session per eye, but it's highly patient dependent. So some tips in doing PRP. Number one, during PRP, if your patient is experiencing some discomfort, try to lower your power. If you're not getting adequate burns with a lower power, decrease your pulse duration instead, say from 100 milliseconds to 70 milliseconds. Number two, if you're not getting good burns, increase the power slowly rather than increasing the pulse duration. I rarely go higher than 500 to 600 milliwatts because if you're not getting any adequate burns with higher power settings, investigate why. Most commonly, it's due to poor media clarity. Therefore, going so much higher with the power settings won't work. You will need to address the media opacity. If you have cataract, might need to remove the cataract, or if it's vitreous hemorrhage, I think you need to refer to a VR specialist to address that. Number three, try to do laser on inferior retina first. If you are planning on doing multiple sessions, anticipate occurrence of vitreous hemorrhage, which will preclude your view of the inferior retina. For single sessions, still try to do inferior retina first because towards the end of the procedure, the patient might be exhausted already and you would have to counter Bell's reflex. Number four, avoid confluent laser marks on and around neovascularization or membranes to prevent hemorrhage or traction on the retina. Number five, avoid the long ciliary nerves at the 3 and 9 o'clock positions to minimize pain, post-PRP mydriasis, and accommodation loss. Number six, always check for adequacy during follow-up. There is a tendency to be too far away from the fovea temporally. That's okay, but take note that if your retinopathy is not regressing as you would have expected, pay attention to temporal retina. Remember that you can go a little closer towards the fovea, but no more than 2 to 3 disc diameters from the center. Also, if you're not getting enough regression, inspect your periphery because you might need to add more laser shots peripherally. Number seven, take photos of your fundus, especially if you're monitoring a specific area. Wide field photos are ideal but are not always available. Photos and meticulous clinical examination are valuable nonetheless. Lastly, do not hesitate to add more laser on follow-up. PRP is not a one and done deal. It goes as far as counseling patients as to what's next. A study reported that 39% of eyes had a repeat PRP after initial treatment, most of which were within 1 year. The strongest risk factors for needing additional PRP were presence of neovascularization on the disc at baseline, early onset of diabetes, and a shorter duration of disease before PRP, probably because these patients had poor follow-up and were diagnosed late. Poor visual acuity at baseline was the only risk factor for poor visual acuity at 1 year. 10% of the eyes had a vitrectomy within 1 year of initial PRP. Take note that it is higher than the ETDRS 5-year cumulative vitrectomy rate of 5.3% because the ETDRS excluded patients with visual acuity of 2200 or worse, or eyes with high-risk PDR as defined by DRS. This study also showed that poor visual acuity at baseline was a strong predictor of traction retinal detachment and vitrectomy. Now let's go on to the cases. My first case is that of a 44-year-old male who had pars plana vitrectomy, endolaser, silicone oil injection for PDR with traction retinal detachment in 2015. However, we lost the vision to neovascular glaucoma. The left eye during that time in 2015 had PRP. He had traction membranes along the vascular arcades, and we were worried about potential traction on the inferotemporal vascular arcade. Vision at this point was good at 2025 to 2030. We decided not to do anything aside from the PRP. Now, fast forward to 2022, he remained stable. The membranes remained stable throughout the years, and his present visual acuity with correction is 20/30. So the lessons for this patient is that poor visual acuity at baseline, such as the right, is a risk factor for poor final visual acuity. And patients who have PRP prior to visual acuity loss are more likely to have better visual acuity on follow-up, such as for the left eye. The second case is that of a 57-year-old female who's been diabetic for more than 10 years. She has poor blood sugar control, poor blood pressure control. Not that she's not doing any effort, but it was really difficult for her to control her blood pressure and sugar. We were so focused on the sugar, but we later found out that she had poorly controlled blood pressure. So we did PRP on both eyes. However, after 3 years, the left eye developed pre-retinal hemorrhage from a neovascularization on the disc. After careful inspection, we did not see any traction membranes threatening the macula or the periphery. We decided to give her an intravitreal injection of bevacizumab, which afforded relief from the vitreous hemorrhage and regression of neovascularization on the disc. So my lessons for this patient is keep the blood sugar stable over time. Do not neglect blood pressure and cholesterol control. And combination treatment with intravitreal injection of anti-VEGF should be considered in patients who don't have any contraindications, such as recent stroke or heart attack, intraocularly without traction retinal detachment and traction membranes threatening the macula. They would benefit from combination treatment. The third case is that of a 67-year-old Caucasian male who presented with left vitreous hemorrhage pre-pandemic. During that time, we did PRP on both eyes. However, he was lost to follow-up due to the pandemic, and partly due to the pandemic. When he came back, the left eye had neovascular glaucoma, which needed intravitreal anti-VEGF injection and glaucoma valve surgery. The prognosis for the left was poor, vision remained poor. For the right, visual acuity during that time was 20/40, but he had a posterior subcapsular cataract, but he was quite happy with his vision, and it was difficult to convince him to have cataract surgery. At first, I was thinking of having it removed or removing the cataract because the PRP was clearly inadequate, and his retinopathy was active. I can see some intraretinal hemorrhages and neovascularization on the disc. So after careful counseling, we decided to give him intravitreal injection of bevacizumab, which regressed the neovascularization on the disc. However, after a few months, retinopathy became active and we can see NVD again. So during this time, I discussed with him that he needed completion of PRP. And for me to do that, we need to take out the cataract. So we did the cataract surgery, which improved his vision to 20/20. Since his vision improved, it's very important to counsel patients that visual acuity is not a good marker for the severity of diabetic retinopathy. So for this patient, we took photos and we showed the photos to him. And you can see in the photo on the right, that's post cataract surgery, that the PRP is inadequate. We don't see any shots close to the temporal retina and close to the arcades. So we did completion of PRP and moved towards the fovea and spared about 3 disc diameters away from the fovea and put more laser marks closer to the arcades. So the lessons for this patient is we need to complete PRP. We need to address media haze. So if it's the cataract, might need to discuss early cataract surgery, and it's very important to discuss risks and benefits of each modality to the patient. Second, we can consider intravitreal injection for patients with active retinopathy, provided there are no contraindications. Also take photos and study your photos because it's more objective, and these photos will protect you. And you're able to show these photos to patients because some patients ask a lot of questions. So again, as far as PRP is concerned, I mentioned that this is a Caucasian male. Specifically, to point out that the fundus is slightly pigmented, so I had to increase my settings, increase the power, and increase the pulse duration of my usual 20 milliseconds to 30 milliseconds. So the fourth case is that of a 27-year-old female who has hydrocephalus and underwent ventriculoperitoneal shunt. She has poor blood sugar control. She presented with bilateral proliferative diabetic retinopathy with traction retinal detachment and vitreous hemorrhage. When she presented last year, the left eye was active, had vitreous hemorrhage, and she needed surgery. So this photo on the left shows the resolution of the hemorrhage after the PRP. I know it's still surgical. We planned for surgery for this eye, but it was delayed due to the circumstances of the patient. Her father passed away from COVID and Typhoon Odette happened in Cebu. So when she came back this year, her vision on the right dropped because of vitreous hemorrhage. And this one became quiescent but very fibrotic. So we decided to do surgery on the right because her vision was so poor that she was having trouble ambulating and navigating. So we did surgery on the right. We gave her an intravitreal injection of bevacizumab 5 days prior to, I think 2 days prior to surgery. And this is the post-op picture of the patient with a gas bubble on top. She eventually had a visual acuity of 20/20. So the left eye is still pre-op. So lessons for this patient is advanced PDR with good view still benefit from PRP prior to surgery. And surgery can have excellent outcomes as this right eye, which ended up with a 20/20 vision post-op. So when to refer your patients to a VR specialist? First, if you're not comfortable with the management of diabetic retinopathy or you have no access to laser, you may refer your patients to a VR specialist. Next is if you have complex cases and you need a second opinion, I think your VR specialist would be glad to see your patients for you. And lastly, if your patients are surgical, such as vitreous hemorrhage, traction retinal detachment, or combined traction and rhegmatogenous retinal detachment, and patients with vitreomacular interface changes, which is fairly common, especially in patients with anomalous posterior vitreous separation, which is common in diabetic patients, please refer your patients to a VR specialist for management. So in summary, my takeaway messages are PRP reduces the risk of severe visual loss by more than 50% in patients with PDR high risk. Although intravitreal injection of anti-VEGF has similar and possibly superior results versus PRP, PRP is still the standard of care, especially in the setting where we lose patients to follow-up. Third, with all the recommendations on PRP settings in mind, remember that the clinical goal is to administer enough laser burns to ischemic retina to induce regression of NVs and prevent new lesions or hemorrhage. Fourth, do PRP immediately upon diagnosis. Delaying PRP for more than a month may cause decreased visual outcomes at 1 to 2 years. Lastly, and probably most importantly, take care of your patient and not just the eyes. With that, I end my talk. Thank you very much for listening, and I'll be glad to take your questions during the open forum. Have a nice day.